A good day to everyone. My name is C.V. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome you all to today's Research in Progress webinar on the interorganizational relationships, infrastructure variation, and public health system efforts to address prescription drug abuse. Before we begin, we'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. We'd also like to remind everyone that at any time during the presentation, if you have any questions, you can type your questions in the chat box located in the lower left-hand corner of your screen. So for today's agenda, I'll first introduce our presenters, and then they'll be giving their talk, and then I'll be introducing our commentator also for today. And at the end of the commentary, we will open the webinar to questions and discussion from the audience. So let me begin by introducing our speakers for today, beginning with Dr. Lainie Rutkow, who is an Associate Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health and co-director of the Johns Hopkins Center for Law and the Public Health. Lainie is jointly appointed in the school's Department of Health, Behavior, and Society and core faculty of the school's Office of Public Health Practice and Training, and is affiliated with the school's public health preparedness programs. Lainie's work concerns the use of law as a tool to protect and promote the public's health in areas such as emergency preparedness, injury prevention, food and obesity policy, and the regulation of industries. Lainie has published numerous articles in these and related areas and is affiliated with the Eastern region of the Network for Public Health Law. Our other speaker is Dr. Kate Smith, who is a professor of health, behavior, and society at the Johns Hopkins Bloomberg School of Public Health and co-directs the MHSS in Social Factors in Health program. Dr. Smith also directs the Center for Qualitative Studies in Health and Medicine. Kate is a sociologist with research interests around the social determinants of health behavior. Her particular area of expertise is communication of health information, and much of her research is organized around individual and collective understanding of health issues and experiences. She was also an author of the NIH Best Practices in Mixed Methods Research for the Health Sciences. So with that, I'd like to turn it over to you, Lainie and Kate.
Great. Thank you so much, CB. And before we begin, I also want to thank the Systems for Action team for hosting us today, and particularly Ann Kelly, who does so much behind-the-scenes coordinating for this series. So some of you may remember that about a year ago, perhaps a little more than that, Kate and I spoke to provide some very preliminary results from the work that we'll be discussing today. Now that a bunch of time has gone by, we're able to share our final results from this project. So the title is up on the screen in front of you. Our project concerned ways that state public health systems are addressing misuse of prescription drugs, and we particularly focused on prescription drug monitoring programs, also known as PDMPs. I should say that when we first wrote this proposal several years ago, most people had not heard of a PDMP. The world is a different place today, and when I tell people about this work, they tend to already have a much better sense of what I'm talking about than they did just a few years ago. I want to take a moment to introduce you to our project team. So I'm Lainie Rutkow, and I am a public health lawyer by training. My colleague, Kate Smith, who you'll hear from in a moment, is a sociologist by training. Caleb Alexander is a practicing internist and a pharmacoepidemiologist. Jan Vernick is a public health lawyer, and we were fortunate during this project to work with two great doctoral students, Beata Dubinsky and Alden Lai. We also had an external, what we call a public health practitioner advisory group for this project, consisting of Corey Davis, and Corey will be providing commentary later in this presentation. Corey is a public health lawyer. Jeanette Manning with the National Association of Attorneys General, and we also had a representative from the PDMP Center of Excellence at Brandeis University. And of course, we want to acknowledge and thank the Robert Wood Johnson Foundation, which provided support for the work that we'll be discussing with you today. As I said, when when we first started talking about the challenges related to prescription drug misuse, it was at a moment when this problem from a policy perspective was just beginning to be approached. And we'll get to the specific policies in a moment, but I wanted to provide some general background about opioid use disorders, since those are really at the heart of the work we'll be talking about today. So unfortunately, opioid overdose deaths continue to increase both in the United States and throughout the world. Among the more recent data, we know that there were over 15,000 prescription opioid overdose deaths in 2015, and unfortunately, the trend suggests that those numbers are going to hold steady or perhaps even grow. There are many different factors that contribute to why we're seeing what people now refer to as this epidemic of opioid and particularly prescription opioid use disorders. And one reason, and there are many reasons, but one reason, and the one that we'll focus on quite a bit during this presentation, concerns the high volume of opioids that have been prescribed by healthcare providers over the last 20 years or so. Opioids are the most commonly prescribed class of medication, and we know from looking at trends in prescribing that as prescribing of opioids has increased, unfortunately, so have opioid use disorders and opioid overdoses. Now, so I just gave you the outline of what is clearly a major public health problem. On the policy side, and particularly at the state level, we've seen a variety of approaches to begin to address it. If we look just from 2010 through the present, it's quite a dynamic legal environment among the 50 U.S. states. So there's been a very rapid proliferation of statutes and regulations. So the types of laws that are or statutes and regulations have the force of law behind them. And then we've also seen a lot of guidances. And you can tell by the nature of the word, a guidance doesn't have the force of law behind it, but it can provide direction. So here you might think about something like opioid prescribing guidelines. Now, many of these laws, because they've been put in place so rapidly, have really lack an evidence base. And that's in part where our project comes in. Our work contributes to things on the qualitative side, and in a moment I'll give you a sense of what the broader research looks like in this area. So there are as I said, there are many laws that we could focus on, and I think perhaps Corey may speak to some of the other major laws of interest later in this presentation, but for our purposes, we're just going to talk about prescription drug monitoring programs, and these are now implemented, or in the case of Missouri, the intent to implement, in all 50 states. And the PDMP is an electronic database that collects information about individuals' prescription drug history. The information in the database is often used as a proxy for use, meaning ingestion of prescription drugs. Of course, we don't actually know that, because the way that information gets into a PDMP occurs when a prescription is dispensed. So PDMPs draw on dispensing data, and they are state-specific. So the map that you see in front of you shows PDMP legislation, so the laws that have been used to establish PDMPs across the 50 states. This was in 2000, so this is 17 years ago. And if you look at the legend at the bottom of the slide, you'll see that green indicates the existence of a PDMP. So a state has passed a law and established a PDMP. The yellow and red categories don't yet appear on this slide, but you'll see them in a moment. So yellow will be PDMPs where by law prescribers must register with the PDMP. And then red are PDMPs where by law prescribers must query the PDMP. In other words, they must actually look up an individual's prescription drug history in at least some circumstances. Okay, so again, what you're seeing right now is what things looked like in 2000. Now jump ahead 17 years, and you can get a real sense of what I mean, that this is quite a dynamic legal environment. In addition to states that have established a PDMP, these are the green ones, that don't have requirements related to registration or query, you'll see that now a large number of states, it's more than half, require either registration with the PDMP or actual use of the PDMP. I apologize for the sirens. Kate and I are sitting in my office in East Baltimore, and sometimes it's just like that here. So I'm just going to go back one slide so you can see once again this dramatic difference. So this is 2000, the legal environment, and this is today. And this is just for one type of law that's meant to address opioid use disorders. Okay, so I already mentioned the key goals of PDMPs, and on this slide what I wanted to highlight is that in addition to the ways that these laws can vary relative to requiring prescribers to enroll or requiring prescribers to actually use a PDMP, they vary in other ways too. So for example, state laws determine who can actually access the PDMP, and depending on the state, it could be prescribers, pharmacists, members of law enforcement, licensure boards, and that variation also, as you can imagine, impacts what and how what PDMP data are used for and how those data are actually used and the types of information that's being looked at. For example, law enforcement is often interested in looking at trend data to try to identify instances of prescription drug diversion through PDMPs. I said a moment ago that I would try to give you a sense of the research environment into which our study entered. So when we were writing this proposal, and this is still true today, most of the research about PDMPs has been quantitative. So the goals have been to measure a state's PDMPs effectiveness in terms of things like prescribing. So is a PDMP having an impact on prescribing practices? Is it reducing, say, instances of high-risk prescribing of opioids? Research has also looked at who's actually using PDMPs. Are prescribers indeed making use of this tool? And this is particularly relevant at a time before states were requiring use of their PDMPs. And are PDMPs indeed being used to identify doctor shoppers? So these are individuals that go to multiple prescribers seeking out, say, prescription opioids, either with the intent to use them themselves or to divert them into the illicit market. Now, most of the research that's out there has not accounted for what we see as the natural experiment in legal and structural variation among PDMPs. And what I mean by that natural experiment is that there's a lot of variation out there, and we don't know what it means relative to PDMP's function and ultimate success. PDMPs are housed in different agencies, and in a moment I'll show you a map of the country to give you a sense of what that means. But some PDMPs are housed in a health department. Others are housed in a regulatory agency. Others are housed in a law enforcement agency. We hypothesize that might impact the kind of work that a PDMP is doing. I mentioned previously that there are variations by law in who can access a PDMP's data. And the reason that we care so much about whether or not PDMPs are effective is because as a policy, they've been disseminated rapidly throughout the country, so we're now at a point where every state either has or has the intention to set up a PDMP, and yet we have a relatively weak or small evidence base. And so we hoped that our research would be able to fill a gap on the qualitative side in terms of better understanding the structure and function of PDMPs. The map that you see right here shows by state the agency in which PDMPs are housed. So if you look at the legend in the bottom of the slide, you'll see that states that are dark red house their PDMP in a board of pharmacy. States that are orange put their PDMP within their health department. Green, the PDMP is in a law enforcement agency. And the blue was our catch-all category for states that house their PDMP in a different type of agency that doesn't clearly fall into one of these previous categories. So I can tell you just from the numbers that we've collected that most PDMPs, but most meaning a majority, but just by a hair, are housed in a state's board of pharmacy. these are our project's aims, and we're not going to present our results aim by aim because what we did was try to address all of our aims through the interview guide that we developed and also through a media analysis that Kate will tell you about in a moment. But you can see from the words that I've highlighted here that the key things that we were interested in are interorganizational relationships, so particularly how a PDMP and its home agency are related to other agencies within the public health system, how the scope or clarity of laws that establish PDMPs affect their functioning, and also how PDMP's infrastructure plays into its functioning as well. And of course, at the bottom of the slide, I wanted to mention that all of these questions were influenced by the PHSSR research agenda. To give you a big picture sense of our methods, as I said, our overall analytic goal was to just better understand these how PDMPs fit within complex state-level public health systems. And to do this, ultimately, we decided that we would settle on 4 case states, and that's because there's so much variation out there. We picked 4 states that are representative in the types of PDMPs that they have and where their PDMPs are housed. So at the bottom of the slide, you'll see that the primary sampling characteristics that we looked at when choosing the states that we would focus on were duration, meaning how long had their PDMP been in effect, what agency did the PDMP sit in, and the size of the state. And ultimately, we settled on the 4 states that are highlighted here. And you can see, this is the same map that I showed you a few moments ago, but with everything blacked out except for the states that we focused on. We deliberately chose 4 states with the help of our practitioner advisory group that house their PDMP in different places. So Florida's PDMP is in a Department of Health. New Jersey's PDMP is with a primarily law enforcement agency. Ohio's PDMP is in a board of pharmacy. And Kentucky's PDMP is in an agency that's called the Cabinet for Health and Family Services that really fit into that blue other category. For the part of our research that I'll be presenting, we conducted semi-structured interviews in each of our case states with folks that we identified along with our advisory group as PDMP stakeholders. So this included staff who work directly for or administer a PDMP. We also spoke with individuals in the State Attorney's General Office who liaise with the PDMP, individuals who work for state medical licensing boards, and a host of other state actors. With permission, all of our interviews were recorded and transcribed, and as I mentioned, our interview guide was developed by our study team, the folks that I showed you on our initial slide, and then reviewed, and we received feedback from our advisory group. On this slide, you can see we use standard qualitative research methods in terms of our coding process. We used in vivo qualitative research software to actually code our transcripts, and that coding in turn was very helpful as we identified themes within and across our 4 case states. So let me move on now to our results. We ultimately conducted 37 interviews. I conducted these interviews myself. I learned a whole lot about the different state environments relative to prescription drug monitoring programs. And you can see here across the 4 states, we didn't conduct exactly the same number of interviews, and that's because we were looking for data saturation, meaning that we reached a point where we were learning no new information from our interviews. I've also provided a breakdown among our interviewees to give you a sense of how many identified themselves primarily as health-oriented and how many identified themselves as primarily law enforcement-oriented. So now, going back to our original project aims, Aim 1 concerned interorganizational relationships, Aim 2 concerned scope and clarity of legal powers, and Aim 3 concerned infrastructure and function of PDMPs. So I'll walk you through results relative to each of those aims. So thinking about interorganizational relationships, we heard a lot from our interviewees about how their PDMP success hinged not only on interagency relationships, so meaning, for example, if the PDMP was in a health department, how the health department worked with, say, the Attorney General's office or with the Board of Medical Licensure, but also the importance of intra-agency relationships. In other words, the PDMP, if it's housed in a health department, for example, it's important that it be well integrated into that department itself, since there are so many pieces of a health department or a different regulatory agency that can potentially augment a PDMP services. Data quality and protection. So one of the concerns that's been expressed about PDMPs is how those data can best maintain privacy and confidentiality, and who will actually be able to access them. So we heard from interviewees that in general, folks feel like they're doing a pretty good job with data quality, with protecting their PDMP data and respecting all of the privacy concerns that go along with it, but there are moments where maintaining data quality and integrity can be challenging. So, for example, we heard that in some states, if human error occurs, so for example, someone inputs PDMP data, but they accidentally make a mistake once it's been, and they need to correct it once it's been submitted, that can be very tricky. And it sounds quite bureaucratic, but the reality is that not being able to easily correct mistakes can have real-world consequences when prescribers are trying to pull up individuals' reports. And speaking of prescribers using PDMP data, the final thing I wanted to mention under interorganizational relationships is that we heard across all 4 states about the importance of integrating PDMP data into electronic medical records. And the reason for this is to make it as easy as possible for prescribers to access PDMP data. Now, some of the states that we focused on had already done this, or they were at the forefront. Ohio was already pretty far into this EMR integration. Other states told us that they see this more as an aspiration, but it's not necessarily a place that they'll be at anytime soon. I know that there is great interest among our interviewees and others in seeing evaluations of whether the integration of PDMP data into EMRs makes a meaningful contribution from a prescriber's perspective. So now moving on to scope and clarity of legal powers. Our interviewees spoke quite a bit about the importance of a PDMP's home agency having regulatory or enforcement authority in terms of the laws related to the PDMP. In other words, it can be difficult if the agency that houses the PDMP is entirely divorced from the agency that can actually enforce laws associated with the PDMP. Required registration versus required use. So I mentioned earlier how states have increasingly passed laws that either require registration, or in some cases states call it enrollment, with the PDMP by prescribers, meaning that they are required, if you are a prescriber, to set up an account with your state's PDMP. It doesn't mean that you have to use it, but you must by law maintain an account, versus states that require use of the PDMP, meaning that in specific circumstances, for example, the issuance of an initial prescription for a Schedule II drug, a state may require that a prescriber actually look up an individual's record in the PDMP. Our interviewees talked quite a bit about the proliferation of these types of laws and how it's not yet clear whether these laws, required registration or required use, will indeed impact prescribing practices. We're rapidly moving to a point where some of these laws have been in place long enough that they can begin to be quantitatively evaluated. And finally, under this scope and clarity of legal powers area, clarifying access and use. So studies of prescribers, so not our study, but other studies of prescribers have found that one of the biggest barriers to PDMP use is something as simple as how do you actually register? Can registration become more seamless? Can PDMP data be easier to access, meaning that once the query is run, can they be retrieved more quickly? And consistent with those other studies, we heard similar things from our interviewees, namely that that when there have been complaints among prescribers about their PDMP, it's had to do with ease of registration or ease of use. Finally, for infrastructure and function, our interviewees talked about how the PDMP was primarily intended to be a tool for healthcare providers, and there was fairly good consensus around the idea that the PDMP should be used to improve patient treatment decisions. Now, that can mean a lot of different things. It could mean that prescribers decide to either to prescribe, say, a lesser dose or a shorter course of an opioid, or perhaps they decide to use an alternative treatment to an opioid altogether. And then a secondary use that was identified by our interviews in most states was that the PDMP could potentially be used by a tool, in some cases by healthcare providers, but primarily by law enforcement to identify doctor shoppers. Okay, I'm now going to pause for a moment and turn things over to my colleague Kate Smith, and we have to switch seats so she can be closer to the microphone, so please just give us one moment.
Hi, everybody. So now to turn to the second part of our study, which was a very nice complement to the interviews that Lainie's just described, and that was our comparative case study of PDMP news coverage from our 4 case states. And we did this study of news in order to provide a proxy for public discourse about the problem that PDMPs potentially solve, as well as how which stakeholders were being given voice in the debate, and what were the issues related to PDMPs that were garnering public attention. And from a social science perspective, there are various different theories that lead us to understand how public discourse, and in this instance news discussion of a topic such as PDMPs, has the potential to shape how people understand whether an issue is important through agenda-setting theory. We know that news plays a role there, as well as how people understand what the actual problem is, and who has a place or a role to play in addressing a problem, as well as what potential solutions even make sense. So from framing theory, we understand how public discourse can shape how people understand both the problem and potential solutions. So what we did for this media study was to structure a pragmatic sample, just select one major newspaper that we could actually have access to through online sources from each of the states. So you see the 4 newspapers that were selected here, and what we did for the study was we had different starting points, so we didn't have equal time periods of consideration for PDMP coverage in each of the states, because not all of the states had been considering or engaging with the idea of a PDMP for the same amount of time. So we accounted for that in our approach and our analysis, but we went for each of the states to a year before any policy action was taken on a PDMP, or definitive action was taken on a PDMP, and looked at coverage from a year before through the present time of when the research was conducted, which was the end of 2015. And we took a common coding, so we collected articles from the 4 newspapers from these time periods, and we took a common coding approach to newspaper articles across all of the states in relation to to the primary terms and content that we were looking for. But we also acknowledged and built into our methodological approach some state-specific terms, such as in Kentucky, the PDMP terminology of Casper that we learned from some initial from our initial review of articles, that we would miss a lot of relevant coverage if we didn't have some state-specific terms. We had our coding approach was both structured and summative, and we had a focus on coverage content rather than a close analysis of tone or argument employed in the content. Our coding framework included a priori codes of mention of state agencies that are housing the PDMP, and other codes were developed inductively through engagement with the news content, as well as the use of the PDMP stakeholder interviews that Lainie just described. So now let me just tell you a little bit. Here we see the kinds of questions that we were asking of our news articles in our coding process, and they relate to the overall aims of the study and what we could learn from the public discourse and the news media about how people were thinking about PDMPs and the problems they were set up to address. So now let me jump to our major results. What we found was, even accounting for the varied timeframes that we looked for, we saw considerable coverage volume variation between the states when thinking about comparable time periods. We found that most articles presented PDMPs in relation to prescription drug abuse as a pressing social problem for which a systems-level solution was potentially appropriate. We saw considerable use of the term epidemic to convey severity and to call for policy solutions. The volume of prescriptions in the state and the negative health consequences, such as overdose and deaths, were commonly referenced in order to provide context for PDMP discussion. The issue of PDMPs generated considerable engagement by political and thought leaders through editorials, op-eds, and columns, and most coverage was supportive of the idea of PDMPs as a systems-level solution. We saw coverage of PDMPs as being driven by a wide variety of events and issues, and proposed legislation regarding the establishment, modification, or funding of a state PDMP was a common source of discussion of PDMPs across states and tended to provide detail about the nature and organization of the PDMP as a system. PDMPs were often mentioned in the news and articles about opioid-related arrests or deaths, discussions of related policies regulating prescribing practices such as pill mill laws, or discussions of educational efforts regarding prescription drug abuse. And such articles tended not to include information about PDMP structure, which is a core interest and focus of this particular research initiative. We saw the issue of within-state interagency data sharing was included in most coverage in 3 of the 4 states. It was actually only covered in about slightly less than half the coverage in Florida. But Florida and Ohio stood out in relation to privacy concerns being raised more frequently in these states than in the other 2 states. We saw more inclusion of politicians and law enforcement officers in the coverage than physicians, pharmacists, or civil servants. And thus there seemed to be more voice being given to shaping the public discourse about prescribing drug abuse policy solutions in relation to law enforcement perspectives rather than health perspectives. So in sum, in this analysis, we saw that PDMPs were routinely presented as a response to an urgent public health crisis. But at the same time, the media's framing of PDMP impact tended to emphasize the role of PDMPs in law enforcement rather than any capacity to protect the public's health. Voices presented were more likely to be those of police and politicians and those of health-oriented agencies within the public health system. And this suggests that there's considerable room within media coverage and subsequently, we would think, among public discourse to convey how PDMPs can function as a tool to address prescription drug abuse and diversion within the public health system.
Thanks, Kate. This is Lainie again. So just to wrap up our portion of today's presentation, I wanted to give you a sense of what we're doing in terms of translation and dissemination activities for this work. So we have several publications in the works. We have one that was recently accepted that will be appearing in the peer-reviewed literature soon. We've given presentations for NAG, the National Association of Attorneys General, as well as ASTO, and we've also given conference presentations in other venues such as the American Public Health Association's annual meeting. For dissemination, what you're seeing here is a screenshot of our project website, and that's housed here at Johns Hopkins in our Center for Law and the Public's Health. We've done several blog posts appearing in different venues, including the Network for Public Health Law and the Johns Hopkins Center for Injury Research and Policy, as well as other social media. And finally, of course, we don't know precisely what impact our findings will have, but what we hope is that this work will provide some sense to state-level policymakers about the way that PDMPs are functioning, and perhaps give clues about the types of interorganizational linkages or collaborations that may be most beneficial. So with that, Kate and I say thank you, and we'll pause to turn things over to Corey.
Thank you, Lainie. Thank you, Kate. And before I introduce our commentator for today, I'd just like to remind everyone that you can type in your questions at in the chat box in the lower left-hand corner of your screen, and we'll get to those questions after our commentary and our discussion. So our commentator for today, Corey Davis, serves as the Deputy Director at the Network for Public Health Law's Southeastern Region, and is also Staff Attorney at the National Health Law Program. Before joining the NHELP, Corey served as an employment rights attorney at Equality Associates Pennsylvania, and previously oversaw a street-based legal clinic cited at Philadelphia's Syringe Exchange Program. In both of these positions, Corey provided direct legal representation as well as education, outreach, and strategic advocacy. Corey has also worked for the North Carolina Institute of Medicine, the University of Pennsylvania, and the Drug Control and Access to Medicines Consortium in both research and management capacities. So with that, I'd like to turn it over to you, Corey.
Great, thank you. I guess my role here is just to kind of give my kind of quick thoughts on this research that Lainie and Kate have presented, and kind of talk a little bit about how it fits into what else is going on and how it might be useful to practitioners. So I didn't get much guidance on how to do that, so I just jotted down some notes from the slides while they were talking. And I'm interested to hear what they think about what I think. So first of all, I would say I think this is really great work. They are right that almost all of the research in this area to date has been quantitative, looking at outcomes of various sorts. We've done some work looking at the actual laws on the books and trying to quantify them. But it's, if you want to know what people are thinking about something, sometimes a really good way to find that out is ask them. So that's great work. I think the newspaper, the media analysis is also, really interesting. It's a really great way to find out what sort of the zeitgeist is around an issue, to see what the papers are reporting, because, not always, but a lot of the times, the reporters are kind of mirroring what is, what the common perception seems to be. So this is really innovative and interesting work. So, when I was listening to the presentation, I was kind of thinking about how it fits into what we know about PDMPs in general, and maybe where we should be going with PDMPs. So as the presenter said, the evidence on PDMP effectiveness is actually not that great. Most of the quantitative work has not been on outcomes that we really care about. It's been on things like, does prescribing change, or does prescribing go down, and that sort of thing. And potentially that's useful, but as we've seen sort of in the medical community, sometimes, if you want to measure whether heart attacks go down, you really should measure whether heart attacks go down, not whether cholesterol levels go down, even if you think the two are related. And the evidence for PDMP effectiveness on overdose reduction, which is really what we care about, presumably, is not that great. There are two recent articles on this one by Bryce Pardo, which seem to find that about half the PDMPs seem to be relatively effective in reducing opioid analgesic-related deaths, and half of them seem to do basically nothing at all. There's another paper by Stephen Patrick and colleagues out of Vanderbilt that seemed to show a reduction in overdose deaths related to PDMPs, but was really heavily driven by results in one state, and when you take them out, you found basically no effect. So I think that this research kind of helps us get closer to two questions. One is, why might that be? and the other one is what might we do about it. So like I said, I was involved in some work where we actually looked at the statutes and regulations that set up PDMPs to kind of see how they discuss the programs. And we found that overwhelmingly those statutes are not framed in terms of public health. None of them mention overdose as an outcome. Very few of them mention improvements in patient health or public health as outcomes. They mainly talk about benefits to law enforcement, benefits to clinicians, and that sort of thing. So I think it's really interesting. Another reason this work is really interesting is to kind of see how that plays out in, in the words of the folks who are actually working for and with PDMPs on a daily basis, as well as the newspaper reports. And my take on it is that this research is generally consistent with what we found, which is to say that everyone kind of talks about PDMPs in the context of, well, these are going to help address, there's a big epidemic and these are going to help address it. But when you get down to the nuts and bolts, there's really not much of a plan to do that. Let me just talk about that for a minute, right? So when you're designing a public health program, which, I would say PDMPs were not really designed as public health initiatives. But when you're designing any initiative, you want to start with a logic model. Where do we want to be? And you work backwards. How can we expect to get there? And it seems to me that the key assumptions behind PDMPs is that you'll collect all this data in a database, and two things will happen. Law enforcement will access it, and they will catch the bad guys, whoever they might be. But primarily, clinicians are going to access the PDMP data. It's going to improve their prescribing decisions, and overdoses are going to go down. I've always been a little skeptical of that theory, and as Lainie said, there isn't a great amount of quantitative evidence looking at that question, but the evidence that we have shows that doesn't seem to be what's happening. You require people to register for the PDMP, or you require them to check the PDMP. That seems to have absolutely no bearing on your ultimate outcome, overdose deaths. And to me, that's not very surprising. Clinicians, mainly physicians, are extremely smart people by and large. And if you don't know that there's an overdose epidemic and that opioid overprescribing is a big driver of it, you must have been living under a rock. So it's not that the doctors don't know in general that there's too much prescribing going on. And it was never clear to me why looking at a particular patient's record in the PDMP would markedly change outcomes. Particularly since, it seems that the most important decision point is really the point of the initial opioid prescription, right? If you have an opioid-naive patient, unless you have a really good reason to put them on opioids, you really should, think very carefully about that decision. But almost by definition, the PDMP is going to help you find people who are already on opioids, typically multiple opioids. You could say, well, we're also looking for folks who are on a benzo and so on. But in general, it's not going to do much for that initial opioid decision. There's also this question of, what do you do? Okay, so one of the goals of PDMP is we're gonna find a doctor shopper. Well, generally a doctor shopper is a human being with the disease of addiction, right? So you found them. What do you do with them? Do you send that information to the state or local health department so they can send out a public health nurse or an addiction specialist? Do you refer, do you try to get that person into evidence-based care or treatment? The answer is no. The prescriber is sort of left to their own devices by and large, and many of them will fire that patient. So now you've got a patient with the disease of addiction who, with the help of PDMP data, has been removed from their source of care. So anyway, all this is to say that PDMPs were not designed to be and are not often functioning as public health tools. So I think that we should think about how to reframe them in that way. One way might be, as I said, to permit public health departments or some other appropriate agency to access those individual level PDMP data to try to connect people with care. That's really not something that should be left up to the individual clinician. That's not their area of expertise. That's not their specialty. Some of them certainly are doing a good job, and when they find a patient who seems to be someone who is outside of their clinical abilities, making the effort to refer that person to where they need to be. But many of them aren't, and that's a key area where we in public health and the addiction field can step in and help that out. And there are a number of things that you can think of to do that. I mean, there's also this question of, do PDMPs make sense in the first place? I mean, as Lainie said, a number of these respondents, noted that the PDMP data are being integrated into EHR systems. Well, why have we designed these separate systems in the first place? They're only collecting controlled substance data, often at great expense and with the big, added bureaucracy and everything that goes along with that. So, anyway, I will end there. I would end with this quote that if you're in the health policy world, I'm sure you've run into at some point, that says that every system is designed to get the results that it gets. So I think we need to think about, are we happy with the results that we're getting from the PDMPs? And if we're not, we really need to rethink the way the systems are set up, the way they're operated, and give much more thought to what we're trying to do with them, and then kind of work backwards from there. So that's all from me. I really appreciate the chance to bloviate.
Thank you very much, Corey. And before we open the discussion to questions from the audience, we'd just like to give Lainie and Kate a chance to respond to Corey's comments.
Oh, thanks. So this is Lainie. I guess our main response to Corey is just a big thank you. It's been a tremendous benefit to us to have him be part of the project, and he is one of my personally greatly valued public health law colleagues. So Corey, thank you so much for sharing your thoughts and for all of the work that you put in as a member of our advisory board.
All right, so let's get to the questions. We do apologize that if we can't get to your questions, we will make sure to forward them to Kate and Lainie, and also invite Corey to chime in if there are any questions that he also wants to respond to. So the first question is from Jay. Unclear what it means for a PDMP to require registration or query. Can you elaborate on this, what it means for that?
Sure. So this is Lainie. When a state requires registration with a PDMP, it's typically called either registration or enrollment, and what that means is that prescribers in that particular state are required either when they get their license to practice or when they renew it to establish an account with their state's PDMP. So literally they have to have a login ID and a password for the PDMP. States that require use or query of the PDMP, by law it means that under certain circumstances, prescribers in the state will be required to actually consult the PDMP before issuing a prescription. So one increasingly common thing that we've seen in the states is that before issuing a new prescription for a Schedule II drug, in some states, prescribers will be required to pull up the patient's history in the PDMP first.
All right. Elizabeth says, thank you for the great talk. One question, how did you choose the newspaper sources? Do you think that political leaning of the newspaper might influence how the PDMPs were discussed?
Sure. So that's a great question. And the first and sort of primary answer is that this was a pragmatic decision. We needed to have a major daily newspaper in each of the states to which we could have access and that there was a good online accessible archive for the period in question. And so the newspaper selection in each of the states was first and foremost that. It was available to us and it was an important news source. But Elizabeth is correct that the political leanings of the newspaper may very well influence the way that the articles are written or what is selected is important to cover, and that's something that we are considering in our discussion of our data in the papers.
So Julia asks, did you run into concerns that the PDMPs were either A, having a chilling effect on appropriate pain management, or B, contributing to the problem of illegal opiate use by restricting access to prescription medications? He mentions that there are common anecdotal observations in Kentucky on these impacts.
Thanks. This is Lainie. First, hi, Julia, and thank you for the question. It's nice to hear from you. So we are in the process of finalizing a short manuscript that within our team we call the unintended consequences paper relative to PDMPs. At the end of our interview guide, we added a question about unintended consequences, either positive or negative, that our interviewees had encountered or heard about relative to their state's PDMP. And the two that you named, chilling effect on pain management or potentially contributing to illicit opioid use, both came up. So we're hoping to get that paper submitted to a journal in the next month or so. So, but thank you. Thanks for raising that.
So before we get to, I think, our last question, Ronald just wanted to share that in Georgia, we have had a change in the PDMP lead agency. It is now with the Department of Public Health and used to be with the Georgia Drugs and Narcotics Agency. So this became effective in July 1, 2017. So I guess you wanted to share that with you guys so you could update your...
Update. I will. I have to update my map. Thank you, Ronald.
And we have one more question here. From Annapurna, and she asks, in terms of use with MAT programs, did you find use of the PDMP can help stem diversion of medications and maintaining compliance to treatment plan, ultimately influencing the positive outcome of the patient? She hears this anecdotally.
So this is Lainie. We did not hear a lot about medication-assisted treatment from our interviewees, but I'm just going to pause for a second and ask Corey, because this is an area where he might have more knowledge than I do. Corey, do you have any thoughts about this question?
Yeah, if I heard the question correctly, it was about MAT, so methadone or medication-assisted treatment. So, I mean, there are kind of two sides of this question. Nearly all OTPs, or methadone clinics, do not report that data to the PDMP because of 42 CFR Part 2 issues. But in general, the MAT clinician, if they're otherwise licensed to if they're otherwise permitted to access the PDMP, they can do that. I don't know about any outcomes, and I don't know if you asked people specifically about that. But so there are some issues in that sense, in that the methadone data won't go into the PDMP. So another prescriber, oftentimes will not know that a patient that they're maybe prescribing an opioid for pain is also on methadone, if they're getting the on methadone for opioid treatment. You don't have that issue with office-based buprenorphine typically. I'm not sure if that answers the question, but so it can get a little complicated, I guess, is the answer.
All right. Thank you, Corey. There's a lot of questions here too, but we'll make sure to forward that to Lainie and Kate. And so we just want to thank them again. Thank you so much, Lainie and Kate, for your presentation, and thank you, Corey, for your comments. Their webinar today will be up and available for download from the Systems for Action webinar archive. So please do check out our website for those. And also we invite you for our upcoming webinars too as well on this Research in Progress webinar series. So once again, thank you, Lainie, thank you, Kate, and thank you, Corey, for your time and presentation and comments. We really appreciate it.
Thank you so much.
Thanks, everyone.